Today is Basics of Narrative Therapy. I've tried to make it somewhat specific to the inpatient hospital setting because that's where we are and that's where you're practicing. I studied this modality when I was in my counseling degree program, and it was the one that really resonated with me for many reasons. One, because of the narrative that we use in the church setting. And at that time, I was working in full-time church ministry, so that really connected with me. My counseling degree is from a seminary, so we used a lot of gospel narrative when we talked about narrative therapy in our training. And so that was an easy connection for me. But more importantly, I think it was really intrinsically what I feel is so important about each one of us individually, and that's our story. And the narrative is about your story. It's connecting with that person that you're with, whatever setting you're in, and giving space, and I call it sacred space, to the story and what they're experiencing, and what I see is their autonomy in that it's their story. I'm not the expert in the room. I certainly have some training and expertise, but each one of us is the expert of our own story. And I can only take it as far as the person in front of me invites me in to take it. So if you can think about it from that perspective today, as we just talk about the foundational elements, a little bit farther into the presentation, we're going to take a look at some case studies because I feel it's always important to take the theory and put it into a real life example to really ground it a little bit. And it may bring forward for you some cases that you've been in and some stories that you've heard. And so at the very end today, we'll have an opportunity to close in a ritual reflection. And so I'd ask you to just kind of hook on to those. And if you feel comfortable sharing those in our ritual at the end, I would invite you to do that too. So what is narrative therapy? It's an approach to counseling that centers people's stories and life experiences, and then it helps them to rewrite and reshape their narratives to promote change, growth, and healing. I'm going to talk to you about some core principles that are a part of that reshaping and changing and healing principles. People are not defined by their problems or diagnoses. And we're going to talk about externalizing in just a moment. Every person is the author of their own life story, and narratives can influence identity and meaning, which impact well-being. So I'm going to take you a little bit deeper into what does that mean. In the role of stories. Think about your own story. And have there been times in your life where someone shared a narrative about you that wasn't exactly accurate or didn't quite sit? So to highlight the role of stories is about our experience, how we remember it, and how we tell the story. So sometimes when we are with patients, they are telling us their story, and their story includes a problem that they are experiencing in that moment. And that may look something like this. I'm here in the hospital. I'm having a really difficult time. I got a diagnosis, and my family and I are not on the same page. And I have anxiety, and that anxiety is driving me to feel A, B, C, or D. Okay. The problem that they have named is what?
Anxiety.
That's the problem. So they have shared with you that they are naming a problem. This is something that they are struggling with. And when they say it in a way that says, I have anxiety, I'm experiencing anxiety. When you're a narrative therapist, you're listening to see if they are internalizing that problem or if they're externalizing that problem. And in that moment, whether it's anxiety, whether it's depression, whether it's addiction, whatever that problem may be, If they are internalizing it, then that may be contributing to other health problems that they are experiencing, right? So, as a narrative therapist, you are looking for that opportunity to hear what they are naming as the problem in their story, and then identifying if there's an opportunity for them to externalize that problem rather than internalize that problem. Thoughts about that before we go to the next slide?
Just
Yeah.
What do you mean exactly by internalizing versus externalizing?
Okay,
Externalizing, I think we are just sort of giving it over to somebody recently.
Yeah, that's a little different than what she's doing,
Okay.
but what you're explaining from what I can tell, so I'll let
Yeah.
Gene, but yeah, I do see what you're saying. It
Yeah.
was externalizing is something we would give over, but in this case, it doesn't. That's not how the system's.
So what do you mean, yeah, by internalizing, externalizing?
so I'm going to talk a little bit more in depth about externalizing in just a second. Let's see if that clarifies it for you. I'm wondering, because I don't know the context of the term externalizing and what you're referring it to. In this theory, it's a tool that you use in order to help the patient center the problem outside of themselves so that they are not seeing it as who they are, but rather as this is a challenge that I face.
So it's not like completely defining them.
Right. That is exactly right.
Okay.
Yeah.
Could that still be like they're not feeling it, I guess? Like what you said, anxiety?
You may feel it, but it is not who you are. Like I am someone else that is more than. I'm a person who has many more attributes about myself than just simply the anxiety that I experience, the challenge that I face. One of the ways that for me really made the light bulb go off as I was studying this in college was people who go to AA and they're required to say, "Hi, I'm Jeannie. I'm an alcoholic." I'm internalizing that. I'm defining myself. I'm saying that is who I am through and through. I'm not separate and a part of, which is different than I am Jeannie. I'm a mom, I'm a grandmom, I'm a wife, I'm an artist, I'm a clinician, I'm all of these things. And I have this struggle, this challenge of alcoholism. And that's what this looks like. Does that help?
Yep.
Yeah.
See it? So right now I'm just going through the foundational parts of narrative therapy. We're going to go deeper into each one of these. Reauthoring is another thing that we talk about in narrative therapy. It's exploring alternative stories to reflect new possibilities. So maybe I'm Jeannie and I struggle with this monster in my life called anxiety. And I see anxiety show up in times when I am juggling many different stressors in my life. And in those times when this monster of anxiety shows up, sometimes it causes me to feel overwhelming. And I am sometimes not able to function as much as I want to be able to function. However, if I have someone helping me reauthor this in narrative therapy, someone walking and journeying with me, because anxiety, this monster, has me frozen, if you will, overwhelmed. This person may find out that as I'm sharing my narrative, there are moments in my narrative where the monster of anxiety is not controlling me. There are actually moments in my day where I am functioning, and that I'm functioning in a very normative way, in a very positive or affirming way. Other people may notice it. Maybe Nakia has noticed that in this meeting that I'm having, I did really well and there was no sign of this monster of anxiety. Maybe Courtney goes to lunch with me and she notices that while we're at lunch, I haven't brought up the monster of anxiety at all. I'm not exhibiting any of these symptoms of anxiety. And so in those moments, Nakia and Courtney are helping me reauthor my story so that then I understand what I thought the monster of anxiety was causing me to be unable to function or overwhelmed. That wasn't really a true narrative, right? So now they've helped me reauthor my story. And then there is this other foundational concept of narrative therapy called externalizing conversations. And I just kind of modeled that for you, where we help the individual separate the person from the problem. Did you notice what I named anxiety? The monster. And that's a technique in narrative therapy where we invite the person in to name the problem, the challenge, the difficulty, something else, to give it a title. Sometimes they might even give it a name, Leroy. I'm going to call anxiety Leroy. When Leroy comes to visit me, then that helps some people externalize it and detach from it even further, right? So tell me about when Leroy came to visit you this week, Jeannie. What were the times that you experienced when Leroy was in the room? And when were the times that Leroy wasn't in the room? Can you name some of those times? So you're balancing out and reauthoring in the midst of the encounter with them.
Jeannie, what's the benefit of taking something like anxiety, depression, overwhelming fear, like any of those things, and giving it a name? How does that help?
It helps separate it from who you are as a person versus this is just a challenge that you're facing. So narrative therapy is a therapy that avoids. It's not that we don't believe in diagnoses, we do, because the diagnosis is important, but a person is more than just the diagnosis. They are more than the problem. So it's helping that person re-identify, reauthor themselves as really who they are, centering them in all of the aspects of who they are as a human or an individual.
So it goes back to that AA example that you had, where it's something I struggle with, not something that is me.
Yes.
So by giving it a name, a
Absolutely.
personal name like
Yeah.
Leroy or whatever.
The monster, or you can just name it the anxiety, the alcoholism. That's very different than saying I struggle with the alcoholism or I'm Jeannie and I'm an alcoholic. Do you hear the difference
Yes.
in that?
And I like the in there because if I say I struggle with alcoholism or I struggle with the alcoholism, that in itself still kind of sets it apart from me because it becomes an entity. So thank you.
Yeah.
That's very helpful.
Absolutely.
Jeannie, would it be safe to say that part of the purpose behind it too, that makes it so good, is that by externalizing it a little, not making it your identity as much, is when it's your identity, it almost seems like it's in your DNA and you can't change it. So how are
Right.
you gonna work on it?
That's right.
Whereas if
That's
it's a little
right.
bit more externalized or it's a little bit more separate, it's part of you, but it's not, it's more external. You can work on it still. It feels like something you can, okay, I can parse this and see how it's best either managed or controlled, whatever the case.
Exactly. Yeah, as you were sharing that, the word cancer came into my mind and thinking, in that description, what does that look like when you're with a person who says, I have cancer? And if you help them externalize that cancer and still remember that cancer is only one piece of the pie, that is that full person sitting in front of you. And they still are and have all of these other wonderful sacred parts of who they are. Cancer is just one of them in a time when sometimes it can feel like cancer has consumed their life and being. We've already talked about reauthoring stories, so I'm going to go to the basic principles of narrative therapy are the stories that shape our identities. The problem is simply the problem. So Vivian, to your point, that's maybe a very simple way to say the problem is simply the problem. That's the externalizing part. Narratives can be deconstructed. So what if I have a narrative about myself that's not accurate? Maybe from childhood, someone created a narrative about me that was inaccurate, and I have carried that with me from my family system my entire life. Those narratives can be deconstructed, and they can be deconstructed through listening to the story, listening for the problem, and listening for the opportunities to reauthor that story as you journey. And then new stories can be created. So how do I develop that new story around, gosh, I've been told since I was a little child I had anxiety, and that's all I've ever heard. That's your anxiety. You need to get over that. That's just your anxiety. Get a hold of yourself, get control over it. Now I can go back and look at the times where someone is helping me reauthor and listen to the other places to thicken my story, and I can create a new narrative that's more accurate about who I am. So stories do shape our identities, how people understand and narrate their experiences. And so I'm going to see if anybody wants to be vulnerable, and it's okay if you don't want to be. If you want to share a story that shaped your identity, that maybe in this counseling process of learning and growing, and in this residency process of learning and growing, you've learned that that story that you thought you knew about yourself might not quite be accurate, that there is a new story that is developing.
I'll go and use myself on something that, it's funny, it was just recently, as of yesterday, it was more of a topic, and even this morning, talking to another gentleman. But part of my story is I served in the military for about 7.5 years. And as doing so, you form a bit of who you are through that. You know, the old adage, they like to break you down and build you back up and create you the way they want you. So it's really a very central part of actually the military. And so, you know, you go through that process. And what's funny is when I got out after serving for about, so like I said, 7.5 years, I found out that I was viewing the world a little differently than I had before, which is I expected that. The civilian world is a lot different than the military, but more so is that how people would look at me and think, because I served, they automatically assumed I'm like the guy who was either in Iraq or did a deployment or saw battle or who, and that is none of my story. Sadly enough, because I mean, it's not you ever want that. I didn't want that, but if needed, I would have definitely done it. I've definitely gone down range. The difference is I didn't. And what that does is it makes me uneasy with who I am when I hear it. Because they'll say, oh, where did you go in theater? Where'd you go? You know, you talk to another veteran, they'll easily go right there and say, hey, where did you go and serve? The problem is I never saw combat. I never saw anything like that. So I don't feel like I fit the identity, even though I served. I really don't feel like I served. Now, I've had this discussion with Faith briefly because of her husband and her experience, you know, with him being in the military, where there's a view of what your narrative is, where they place that on you and what you think it is. And I'm trying to help them understand, oh, no. Yeah, I served, but, and I always want to put that caveat in there to really help them understand what my experience was. I didn't see combat. I wasn't downrange. And what that does is it needs to shift it, especially if it's a fellow veteran, they'll get it immediately. They'll go, gotcha, no problem. They'll know. If it's someone who's a civilian and they hear it and they think you went over to serve, they're not necessarily going to be able to parse and say, well, what does that matter? Well, no, it does matter, because you talk to someone who has served and gone to combat, they'll tell you pretty quickly that, you served, yeah, but you know, you really, it's almost like you really did. So there's this identity issue. It's almost a crisis to some extent that I served, but I didn't. It's almost like someone wants everyone to stand who served in the military. I'm hesitant every time to stand up and own it. Even though I signed up, I took the oath, I was, you know, it's still, I just feel like, and I wore the uniform and I went and did everything I needed to do. The difference is I don't feel like I'm worthy of it. It sounds weird because I know those who have. And while I was serving as a chaplain candidate, I would hear their stories and I'm like, wow. Now that's the stuff like the Band of Brothers show and things you might see that actually reflect what serving's like. And so that's a little bit about an identity thing that I've
Mhm.
had that doesn't necessarily match up with what others might think and how I desire internally to say, oh, no, I don't want you to think I was out there like, General Schwarzkopf going, I mean, it just, that wasn't me. I don't know if that makes sense. And I don't know if that really ties into this where we're
Well,
at.
I was thinking that in terms of the need for reauthoring it, to me, it sounds like that there's a story related to military service
Mhm.
that you feel is a very worthy story. And then you're trying to figure out, where does your story fit into that? And if I was going to work on reauthoring that with you, I would want to know, what else do I not know about your story of your service time that would reauthor your story to show the importance of what you did that does make it worthy in the same way that this story is worthy. So what contribution was it? Similar to how we say in the hospital, the people that are cleaning the rooms are as essential as the nurse, because if they don't clean the rooms, we have infection. If they don't clean the rooms, we can't get another person in that room. If they don't clean the rooms, the patient experience, the score, it doesn't matter what we do, there's going to be a complaint, which then hits our bottom line. So that person, if I reauthored their story, is as essential as the nurse at the bedside, caring for the patient.
Great example. Thank you.
You're welcome. You're welcome. Okay. Next slide. Oh, let's stop just a minute. Let's go to your packet, because I do want to point out some things to you before I get too far into this. Let's take a look at we don't have time to look at all of these examples, but let's just take a look at number one, the first page in your packet that says a bedside encounter example on a medical unit. And Yvette, would you read for us? Thank you.
Scenario. A patient recovering from surgery said, I'm useless right now. I can't even shower without help. Continue.
Mhm.
Okay. Narrative approach. Externalize. It sounds like helplessness shows up when you need assistance. Seek outcome. Was there a time today when helplessness didn't get the last word? You're offering. What would you call this part of your story? The chapter where you're learning to let others care for you. The therapeutic shift. The patient reframes dependence as collaboration and healing through connection.
Thoughts about the example? Does that land and
Yeah.
anchor it a little bit? Okay. All right, let's do one more. Let's do number 3. And Luke, would you read that one? Mark, sorry,
that's fine.
Luke.
Another-
Luke, Mark, Matthew.
Um,
Oh, that's cool.
the team rounding one?
Yeah, let's
Okay.
do the team round.
Scenario, during team huddles, staff describe a patient as non-compliant with pain protocol. Narrative reframed. What story might we be missing about the patient's choices? This be a story of self-protection or seeking control in a vulnerable situation. Outcome, the team shifts from blame to understanding, viewing patient behavior as meaning-making and agency.
So I'm going to pause right there and go back to a little bit at the beginning when I was mentioning that certainly narrative therapy is something that can be utilized in the patient setting or in the client setting, but it could be utilized in other relational settings as well. And I love this example for that, because oftentimes we are the person in the IDT meeting who is the voice of the patient, who is the advocate for the patient. And the team is dealing with so many challenges throughout their day. And sometimes those challenges impact their ability to step back and think, why is this happening? Let me be curious about what I'm experiencing from this patient. Sometimes they lean into the frustration of the situation because they know they have to get to the next patient. And that's just a part of, the work. And this particular example especially, I think, is a situation that I encountered a lot when I was on the floor. And I wonder if you have encountered it, where a patient might be given a label or assigned a narrative that's not exactly accurate because there is something going on. There's more thickening of that story that the other clinician may not be aware of yet. And you're the person who helps thicken the story and helps externalize the problem and then go back and reauthor what that might look like. And you may not have used those terms that I just presented to you, but I'd almost be willing to bet that each one of you has had a situation like that. And whatever model that you're using the terminology of that model to fit that. This is the terminology for the narrative therapy model of it. Does that land? And some of you are nodding your heads. And if something, comes up, a situation that really comes to mind for you, stop me and let's share it with the group, because I think that helps
I was just
ground the
thinking,
learning.
I have a patient, like 3 right now.
Okay, do you want to share that with
Um,
us?
And I just met them yesterday, and when I hit the floor and I talked to the doctor, it's ICU floor,
Mhm.
so I don't always see the doctor, but I saw him yesterday. Hey, how's he doing? What do you need today? And he's like, you need to go talk to that one. He's giving everybody problems. He's being really non-open to treatments and all these other things. See, so when I walk in, he's a 20-year-old that's had cancer for 5 years. And he's been in the hospital here in Jacksonville since June. He started at Mayo and then to us. And he's been with us over 30 days. And so he's disconnected from everybody he knows. His dad came with him, but that's all he has is his dad here in Jacksonville. And he had attempted college and he couldn't do it because of his health. So all of his friends have gone off to college, all these things. So he started talking about his isolation and his loneliness. And the doctors were just like, he only wants these pain meds and he doesn't want this and he doesn't want that. And I remember thinking there's so much more to this than just which pain meds he wants. But I wasn't sure how to navigate that. So that I didn't put myself in the middle of things that I didn't need to be in the middle of. So this is like identical to who he is. He's got 2 holes in his stomach, so he's in a lot of pain. He can't eat. But he only wants certain things. So it's not lining up with what the medical team wants. But I see in him that wanting to try to find some type of independence and control over his life because he's had so little. And I could imagine that's probably why he's so adamant about which things he wants, because maybe they worked in the past and he knows they'll work and he wants that voice. So
Yeah. So you're wondering if this particular situation with this physician and the medication is how he is managing control of some things, because there's so many other things that are out of control in his life. And you're wondering if the provider has thought of that. I'm wondering if this might be what's going on with this patient. When it lands with me, I'm curious if this could be what's going on, and if we might want to explore that with him.
Yeah, and I like the way you put that, because yesterday I shared with the provider, he is saying that he's very isolated, he's alone, he feels like his thoughts overtake him at times and all these things, which are not abnormal things for a 20-year-old who's been in the hospital for so long. But I didn't know how to bridge the gap between the things that I was sensing but weren't my realm. And I think that was where I felt stuck.
Yes.
Because the medical stuff is not my side. But it did seem like these feelings were affecting how we are.
Sounds like the emotions are, which is your side. You are seeing that. You have that opportunity to reauthor his story by giving, everyone on that IDT that information to thicken the story so that they have those other perspectives as well. So that's great insight
So that's
for
something I
you.
could probably talk with him about today, the patient, see if I could get him to a place of at least talking about what he's trying to gain control over and like. that
Sure.
way-
Yeah, I think anytime we have the opportunity to thicken that story because the patient has shared some things with us from the emotional and spiritual side, and we know that that can be impacting the medical side, that we not only have the ability, but we have the advocacy, the power to advocate for that.
So I was gonna say,
She speaks for himself.
I was just gonna say that might be a place where one of us can provide support too.
Oh, yeah, that's a good idea. A place where you could do a referral for some additional support. Mhm.
He, I asked the nurses if anyone from mental health had come because he was completely hopeless. And he said things like, I have bad thoughts, sometimes they overtake me. You know, and so I was like, has anyone come? And she's like, he's kicked a lot of people out. Like
Mhm.
teens come to help him and he says he doesn't want them and kicks them out. And so I was like, oh, which is also isolation. And when patients put themselves in isolation for the people trying to help them. So I didn't think about making a referral to one of y'all, which is,
That's why we're here.
Mhm.
I guess we've never done it. So, yeah, that would be a great next step for somebody who has more skills than me to unpack that. Or we can talk about it
All right. Thank you for bringing that. That's
later.
a,
Thank you for suggesting.
Or,
yeah, and I felt like that really grounded the learning that you're sharing that case too. Yeah, does that help? Okay. All right, and then I want to turn the page to where it says slide 7, the case vignette. The patient background is Jordan, a 32-year-old patient recovering from a complicated abdominal surgery following a chronic illness flare. He's been hospitalized for 10 days on a med-surg unit. He works as a mechanic, lives alone, and identifies as spiritual but not religious. Prior to surgery, he was independent and prided himself on his physical strength and work ethic. So, Patrick, would you read the initial encounter?
Sure. When the counselor enters the room, Jordan says quietly, I hate this. I can't even get out of bed by myself. I feel like I'm weak. Jordan looks away as he speaks, visibly frustrated. His nurse reports that he often declines assistance with daily care and becomes discouraged when he tires easily.
Hey, we're going to stop right there and try not to look ahead. If you haven't read ahead, but try to avoid that. What is the problem? Can you identify it? Okay,
He didn't say that, but that sounds like.
so go back to what he said. Use his words and see if you can find it.
I feel like I'm weak.
Yeah, so that's the
Priding
problem.
himself on physical strength, and then he says, I feel like I'm weak.
Yeah.
less than, less than.
Yeah, okay, great. All right. Hareem, will you read the problem saturated story?
Jordan's dominant story centers on weakness, a narrative shaped by his identity as someone who should be strong and self-reliant. The story says, if I need help, I'm failing. Weakness has become the main character in Jordan's experience, defining his sense of self and diminishing hope for.
Yes. So I want you to listen. So I'm going to go back to the example I gave of myself with anxiety, and anxiety being the monster, and pay attention to how the conversation gets externalized in this example. The clinician says, it sounds like weakness with a capital W. It sounds like weakness has been talking loudly since your surgery. When did weakness first start showing up? Jordan says, probably the minute I couldn't walk to the bathroom alone. And the clinician says, and when weakness starts talking, what does it usually say to you? Jordan says that I'm useless, that I'll never get back to work. The clinician reflects that weakness seems to feed on isolation and pride, but that Jordan is beginning to notice its patterns. That's narrative therapy in action right there, you all, is that weakness becomes the thing, the challenge, the monster, the it, outside of who Jordan is, rather than Jordan saying, I am weak, I am useless, I'm not going to get back to work. Okay. Unique outcomes. Vivian? I may have already called on you to read. If I did, I'm sorry.
When asked about times weakness doesn't take over completely, Jordan recalls, yesterday I actually asked the nurse to help me shower. I hated it, but afterward I felt human again. Clinician. So even when weakness tried to convince you to push people away, another part of you made space for connection and dignity. Jordan. Yeah, maybe that was strength too.
Mm. And so there is the reauthoring already beginning to happen. I'm looking for those opportunities where weakness was not present and something that was different, a different narrative was showing up in the day. So here are some guiding questions, and we've talked about Jordan a little bit. How has the patient been affected by their problem-saturated story? Are there times when the problem has less control over the patient's life? And what alternative stories can the patient envision? I'm going to skip over this because we are getting very close to our time. It's just another case example. So when we're in the process of reauthoring, here is the process. It's identifying the new plot line. Let's go back to the case study that we just read together. The new plot line is moving away from weakness and towards strength and resilience, and finding where those opportunities to witness that in the story came about. It's tracing the history of the new narrative. When have there been times in your history that you have had a place that you felt weak or a problem that you felt like you couldn't overcome, but now looking back, you saw that you did. You had the strength to overcome it. You realized you weren't as weak as you thought you were, and you made it through that. So I'm reconnecting you to something in your past history to thicken your story and reauthor it. Connecting it to the new story and in the present, and then inviting others to support the news story. And we haven't really talked about number 4 yet, so I'll just touch on that briefly. Maybe the nurse has seen times when the patient wasn't weak and helpless and reliant on others. Maybe the nurse can help thicken the story. Maybe the nurse can be another witness to the story. And you could encourage the nurse to share with the patient, hey, the patient shared with me they're struggling with feelings of helplessness. They see themselves as being weak. I'm wondering if over the past few days, have you seen sometimes when they weren't helpless, they weren't weak, that you might share with them to help encourage them to live into this new narrative of their story. So you invite someone else to be a witness. Maybe you as the chaplain, maybe the nurse is sharing with you what the patient has said, and you've already experienced the patient in some other ways. And so you have that opportunity to go in the room and be the witness and reauthor the story. So who are we when we're in the room and we're in the midst of this narrative therapy process? We are collaborative and non-blaming. We see the client as the expert of their own life, and we're demonstrating curiosity always. Tell me more. Tell me why. Tell me how. And of course, we're using active listening, because if we're not beginning there, we can't do any of the other pieces. Right. Hopefully that was not too much at one time to just give a very brief overview of narrative therapy. Thoughts, feedback, curiosities?
I think this is great. This is very applicable, to what we do. And it's funny, it's not just like, in the beginning, I think you said this, it's not just the, seeing a patient in a patient's room in a clinical setting. It's funny how you can look at the world a little bit differently through this narrative lens,
Mm.
and you can, flesh it out. You can look at different things, in our own lives, and then as it applies to other relationships, you know? So kind of like the reauthoring, when I look back at the military angle, that's something to look back at and see how I can see where there might be other ways to look at it. And not only that, but with our patients, it does without a doubt apply. And the staff.
Yeah.
So IDTs. Oh, man. And that's good because it helps us engage and learn on other resources. And it helps us when we engage them to see from their viewpoint as well. So we can get their angle too when they're talking about it as it relates to the patient. So it helps. We learn as well from that. So I think this is good.
I'm excited about the information. I have a patient I've been working with for about a week and a half that been trying to help him reframe. And so I think this is gonna give some good tools
To try out
to try.
some of the resources. There are several resources in here. There are other ways that you can pose questions. There are other examples. So I hope you find that helpful too as you dig a little bit deeper. I'd like to end with a ritual. Are y'all in a rush? Because we're at time and it won't take but about 3 or 4 minutes, 5 tops. Can you give me 5 more minutes for a closing ritual? Because I feel like that's really important in terms of our spiritual practice together. And it's also modeling something that you can do when you're with a patient or a team member when they're having a struggle too. So the ritual centered around just gratitude. And so I'll start it off and then we'll just go around the circle and then I'll end it. A ritual of gratitude for all that was shared today. Moments that you might have thought of something personal that you didn't choose to share out loud, but maybe you're turning it over inside and wondering, how this applies to something that you've experienced in your life or in your professional setting now. I want to say gratitude for all of the things that each of you shared today, whether it was a simple reading that you shared or whether it was something that you added to thicken our story together, or whether it was a problem that you presented that helped us all kind of ground this theory in some way. Thank you.
Grateful for the teaching in itself to give me ways that as I've been reflecting on my patients, to be more helpful. I'm also thankful that y'all gave me space to come in late without all just staring at me awkwardly. Because I was uncomfortable, so I appreciate nobody making me feel more uncomfortable. And I also appreciate Eugenie and giving me space to just jump into the conversation, even though I was late, because those things are hard for me. And I appreciate the things that were shared. Grateful for all of it.
I'm grateful for just another day. I know it sounds funny, but I come from hospice, so a lot of it. So each day is a blessing in itself. Like we used to say in the military, 6 feet above ground. So I'm grateful for that. But even more so, I'm grateful for another tool that can be refined and used that I can help patients and others and even apply in my life. I was familiar with this, but I haven't been using it as I should. So now I'm grateful for the opportunity. Now I'm going to use it more. And I see so much value in it. I appreciate you sharing it. And because there's so much you could have done as a didactic, but this was great. And I'm grateful for the people around here because I've gotten to know you a little bit. And it seems like every time we have a didactic or someone adds something, it's kind of neat. Always learn a little bit new. It's always nice. It's just that's all. Thank you.
Grateful for, I guess, receiving confirmation that I was kind of on the right track with the way I was approaching the bedside, approaching the experience of another or what I was hearing. Because I was already starting to ask them to name something as a thing to external, and I didn't realize I was doing that. That's kind of cool. Like I had this instinct, like, and I knew it was helpful for people, and so I was like, oh, I'm gonna keep doing that. So that's kind of neat. Now I know how to kind of, I fleshed it out. You helped me flesh it out a bit more and understand how I can go deeper, how I can unpack that even more with folks um, and sort of have them maybe reach a bit more catharsis or reach a bit more comfort or understanding, whatever. So thank you.
I think you saw when I first walked in, I was so thankful. It was kind. I always appreciate that. That was really nice. I appreciated that. And I was really appreciative of all the information. Because there was a lot of things that I was thinking about and like the reauthoring and different, like what I think what everybody said, like when you're dealing with your, the patients in the room and just the information, like, oh, okay, yeah, I could have said that, or, oh, I did do it that way, or that could help this patient, because I have a patient that couldn't walk. And he's just yesterday, and he was kind of worried about that, and he said different things. And then things that I could actually add to the nurse with the reauthoring, because the nurses, I speak to them all the time and and I've been doing that, but now I have words for it. So I really appreciate that. And also like, even like what you said, even in your, a lot of things in your personal life came through, like, I've been through this and I've been through that. Like, okay, I can do this. This is good work. I really enjoy it. I'm excited. So I'm really appreciative of the, I guess, the information, the work, and everything that everybody shared. I learned from it. So thank you. And thank you for actually allowing us to be in this space and to, what do I want to say? Pouring into us and investing in our careers and what we choose to do, what we feel like God has called us to do. So I am grateful for that. For that, I just say thank you to.
I'm thankful that I had a good sleep. And also appreciate this complimentary hot coffee this morning. And also I appreciate this very resourceful and practical information that I had today. And I thankful for my insights that I can on in terms of like how to use this information into my practical my practice. And I also thought about all the clients that I met that I could have used this information into. So I'm hope that I could use this knowledge more of in the hospital and inpatient settings.
Thank you. Sometimes it's the little things like the sleep and the hot coffee, right?
I'm just grateful for the opportunities for our two disciplines to kind of cross-pollinate, sort of so much to learn from one another.
Yeah.
Just thankful for how we're able to have this space together. We've been able to get to know you all better during this time. From you.
I wonder if there's opportunity for that to happen, some additional times in the future. When I was doing residency here, I want to say it was once a month that the counseling interns came in with the residents for didactic, which was always a lot of fun to have everybody together. So yeah, that's something for us to consider. Thank you.
Thank you for providing this information today. It's really supportive of my practice, and I appreciate that. I appreciate everyone's shares, and I'm especially grateful to my colleagues whom I deeply respect and admire. And learning from you both every day is what makes me a better clinician. So I'm really grateful to you.
Mhm.
And getting to work alongside Eric has been a great joy in sharing what you're doing from your side with the same patients has been really a supportive asset to my clinical experience as well.
That's beautiful. Beautiful collaboration.
Ditto. It's been great having you as that resource too. So thank you.
Thank you for what you're doing every day. I have no doubt that just your presence alone is making an impact on people's hearts and on their healing journey, whatever that might look like for them. So we are glad you're here. And I don't get to spend a lot of space and time with you all, but I hear what good things are happening, and I hear it from leaders, and I hear it from the clinicians that are on the floors with you. So thank you for that. You are the face of our department when you're out there, and you are the ones doing the hard work every single day and the hard cases. And so we're very, very grateful to each of you. Thank you. Thank you for your time today.
Thanks.
You're welcome. Welcome.
Can you please accept my apologies for me?
Listen, Faith, I knew when we